Hi, my name is Jonathan Spicer. I'm a professor of thoracic surgery at McGill University and the medical director of our thoracic oncology network here at McGill in Montreal. It's a pleasure to be with you today. We'll talk a little bit about using immunotherapy in the context of resectable non-small cell lung cancer. So it's been a whirlwind of data that we've encountered over the last 3 to 5 years. And I think there's two really very important pieces of data to retain here is number one, the use of neoadjuvant or perioperative regimens are associated with statistically significant, very clinically significant overall survival benefits. If we put the sum total of the data together that we have today in 2025, the hazard ratio is 0.65, and that's over and above the hazard ratio of neoadjuvant chemotherapy, which was 0.8 over surgery alone. So what has changed from just a few years ago is that when we have a patient with clinical stage 2 or 3 disease, the regimens that bring overall survival benefit, which is exactly what we aim to achieve for our patients, are accompanied with neoadjuvant chemoimmunotherapy first, then surgery, which is a very important step and one that we must get a maximal amount of patients to complete, and then postoperative immunotherapy in the context of perioperative regimens. The second really critical piece of information is that when patients achieve a pathological complete response, which happens anywhere from 17 to 25% of patients in the intent to treat setting, this is associated with dramatically improved event-free survival and overall survival. And it's clearly the goal for our patients is to try and give them that opportunity to achieve a pathological complete response because it is so tightly associated with amazing clinical outcomes. Currently, the data we have are that patients who achieve a PCR have about 95% overall survival at 4 years. And that's better than what we see for surgical resection of stage 1A disease. So those two pieces of information together are really the main reasons why I personally advocate for neoadjuvant perioperative chemoimmunotherapy for resectable patients. I'm often asked to discuss a little bit the practical considerations of applying these regimens in real life outside of a trial setting. And this is particularly relevant because so many teams have not really had the experience of using neoadjuvant regimens in a high volume setting. They might have used neoadjuvant chemo or chemoradiation for select N2 patients, but now with these regimens and the spectrum of what is considered by most surgeons to be resectable disease being greatly broadened as compared to what it might have been just a few years ago, means that a lot of teams are unaccustomed to the logistics and key steps to consider when applying this approach. So the first thing, there is not always an in-person surgical evaluation performed prior to the implementation of a neoadjuvant chemoimmunotherapy regimen. And I think that this is absolutely critical for many reasons. The first is that surgery is an integral part of that plan. That is the starting point. The patient really needs to be assessed in person by a thoracic surgeon on our team who deems the patient resectable or not. But once a neoadjuvant perioperative regimen is selected with the idea of going to surgery, I personally consent the patient before they even get their first dose. I book them for their surgery, and my central OR booking team knows that that patient is to go to the operating room somewhere 4 to 6 weeks after their last dose of chemoimmunotherapy, and that I need to see the repeat contrast-infused CT, possibly PET scan if your center can afford to do that on a routine basis. And once I've reevaluated the post-induction imaging, then the patient is going to surgery. And at least within trials, it's 100% of our patients, so 80 or so patients who've been on phase 2 and 3 neoadjuvant trials who've all gone to surgery. And in our real world setting, it's about 95%. So the vast majority of patients will complete their neoadjuvant chemoimmunotherapy will go on to surgery, and then we'll have a tumor board assessment about the pathological findings and make some decisions about whether or not the patient continues to adjuvant therapy, taking in particular the consideration whether that patient has experienced postoperative complications, what's their performance status, did they have complications or adverse events from treatment before the surgery during neoadjuvant treatment. So that's essentially our approach here at McGill, and the one I strongly advocate for. And assessing whether or not neoadjuvant chemoimmunotherapy and surgery and then adjuvant are the right set of choices for that patient. You require all of the data that allows you to make that determination. So obviously that means a full risk assessment with pulmonary function tests and further physiological testing to assess resectability if needed, but also includes complete pathological information, PD-L1 testing, next generation sequencing, excluding driver genes like EGFR and ALK at a minimum. And then, of course, the full staging, which in general for patients with clinically evident stage 2 and 3 disease means invasive mediastinal staging to get an accurate picture of the exact clinical stage. So with that information, then we're in a position to help guide patients with what might be the most optimal approach. As a surgeon, I think as most clinicians think in this domain is we're thinking with the goal of cure. We're also thinking with the goal of, maximizing that opportunity while mitigating some of the risks. And there's always a bit of a risk of over treatment in this setting where our staging is imperfect, and some patients with clinical stage 2, even maybe a very tiny minority of stage 3 patients might be cured with surgery alone, but the majority need systemic therapy escalation. But there's a lot of data to integrate right now. So PD-L1 testing and the spectrum of PD-L1 expression is one thing that people often debate. Should we only be treating PD-L1 positives or include PD-L1 negatives? Our approach is really to include all patients. We know that the magnitude of benefit is less in the PD-L1 negative patients, but the chance of PCR is dramatically increased. It's anywhere from 14 to 17% of patients who have PD-L1 negative disease that will have a pathological complete response after chemoimmunotherapy, which is significantly more than the 2 to 4% that we see with chemo alone. So that on its own is one of the reasons why we still consider PD-L1 negatives, and we know that there's a statistically improved EFS benefit when we treat PD-L1 negatives in this approach, which is not at all clear in the adjuvant setting. So that's one important point they think that's important to think about. The other is I think accessibility of next generation sequencing is not equal at a global scale. There's a lot of patients for whom we just don't know what the right thing to do is, and so it's a case-by-case discussion. But in general, we sort of err on the side of maybe over-treating with more systemic therapy because we're aiming for cure. And in general, it's quite a safe approach, especially when it's conducted by an experienced group. I think the other thing to communicate to centers, maybe just starting this or getting into the mode of doing more of this type of treatment, is to collect your data, and to do so in some sort of institutional registry where you're collecting information prospectively so that you understand what your attrition to surgery is, what your complete resection rates are, and how the patients are tolerating the regimens as a whole, because some centers may be better in some domains than others, and it's quite important to perform continuous quality improvement in that domain. Some of the hottest topics, I think, in the domain of resectable disease are pertain to when to give it. Do you give it just before with chemo? Do you give it just after in a sequential manner after chemo? There are emerging trials about concurrent adjuvant chemoimmunotherapy. We don't know what they'll show yet. And then, of course, perioperative, where you'll give it concurrently with chemo and then again adjuvantly. So nobody knows the right answer here because none of these trials have been compared head to head. They've always been compared to the either standard neoadjuvant chemo regimen or the standard adjuvant chemo regimen, but we don't have all the permutations. I think there's a couple important conclusions. If you perform a meta-analysis of neoadjuvant and perioperative regimens, you have a very clear intent to treat. That means all comers overall survival benefit. You cannot do such an analysis on the adjuvant side. We only have 2 out of 3 trials that are positive for disease-free survival. There's only one subgroup that shows overall survival benefit so far, and that's adjuvant atezolizumab for PD-L1 greater than 50%, and also requires the patients to have received chemotherapy. So that, in fact, is a very small group of patients who have had a complete resection after surgery, were fit enough to have at least 1 cycle of platinum-based chemo, and have a PD-L1 greater 50%. And that's maybe 15% of your resected patient population. So it's a very useful regimen, but it's only applicable to a small cohort of patients. On the flip side, when you use neoadjuvant chemotherapy, yes, there are subgroup differences, but on an intent to treat basis, these regimens come with overall survival benefits. Now, why would you select a pure neoadjuvant regimen like Checkmate 816 versus a perioperative regimen, say like Keynote 671? As a clinician, I like to have flexibility because you don't know on day 0 when you sign up the patient for that approach what's going to happen. You may have a patient who has a major adverse event to their first cycle of chemotherapy and now cannot complete cycles 2, 3, and 4 and needs to go to surgery. And we don't know exactly, but there may be a lot of benefit to that patient continuing to have access to immunotherapy after the operation. So that's one scenario that happens and we need to manage. And the flexibility afforded by perioperative is, I think, very important. Another scenario that emerges where flexibility is important is in patients who end up not going to surgery. And unfortunately, in the trials, that's anywhere from 15 to 20% of patients. And we now have data from Keynote 799 and hopefully more data coming from the unresectable setting, showing that Apollo, for example, and other trials that are reporting that indicate that neoadjuvant chemoimmunotherapy followed by concurrent chemo-rads followed by consolidation immunotherapy is a valuable option over what's classically used in sort of the Pacific regimen. And we know that chemo-pembro, for example, followed by consolidation pembro has benefits, and that is available, in a perioperative design. And in a study like Keynote 671, for patients who could not have surgery, who still had disease amenable to local regional therapy, chemoradiation was an in-protocol component of the trial. And so we have some assurance that this is a regimen that's tolerable now with, as I said, Keynote 799, and something that could be of benefit that, again, affords the clinical team and the patient more flexibility. And finally, we know that a certain proportion of patients, depending on centers, depending on surgical management, will have incomplete resections, R1, R2 resections, 5 to 10%. And again, I think there's considerable value for that patient who we know is maybe at much higher risk of recurrence to have access to a treatment which we know can be beneficial, at least in the metastatic setting or in the local regional advanced setting. So the arguments in my mind for a perioperative regimen is that they give the team a lot of flexibility to adjust to how the patient evolves through their course of care, which we know is variable and somewhat unpredictable. And so this approach really gives us the ability to maximally treat when we think it's appropriate, and also to de-escalate, as say if the patient's having adverse events, and minimize exposures based on clinical expertise and patient preference. So that's a quick look at this very dynamic clinical space with a lot of new information coming every few months. Hopefully, this was useful to you in terms of how you approach patients with resectable non-small cell lung cancer.